Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Some seem to be on target and some a little off target, but all worthy of discussion. So let's go. It was nice to see so many people at the cookout. Yeah. Hadn't seen Pearline Freeman in ages. So it was good to see her again. This is an article that just goes into some of the other details about simple details about blood pressure that we maybe didn't talk about before because it's really the elemental aspects of hypertension. What is blood pressure and what do we mean by blood pressure, as you can see here, and what does the blood pressure measure, and what does it mean? And I think these are very simple answers to the question about why do you have a blood pressure? Why does the heart pump have to be at a certain number, and what's systolic blood pressure, what's the diastolic blood pressure, and what difference does it make? And I think that it's good to understand what we're talking about, and also the dialogue about what is the normal blood pressure, 120/80, is still the bottom line, although you have much discussion about whether 120/29 is considered pre-hypertension, or whether over 140 is stage 2. And but I think in general, what we say there is what is true, that if you're over 140, you definitely need to see a doctor, and if you're over 180, then you really need to be treated. And if you're not treated, stroke and other kinds of complications are likely to occur. And while we talk mostly about the systolic, the bottom number is important as well. And the fact that the hypertension can lead to heart attacks, strokes, eye damage, and kidney failure is also important to appreciate. And that's why the earlier you manage hypertension, the better. And then, of course, the fact that hypertension is a silent killer is what makes it so devastating, because you don't know that you have it, and you don't get your blood pressure checked. And since hypertension starts probably around the age of 10, and so it gets important to get your blood pressure checked so you know what's happening, especially with people of color, Native Americans, African Americans, and Latino Hispanics. Start getting the hypertension at very young ages, so important to do it. Low blood pressure is something that is symptomatic, though, because you get dizzy and lightheaded and other things that alert you to low blood pressure, and of course you faint, and so that low blood pressure is not good either. And so, and we end by talking about the fact that stress, lack of exercise, lack of sleep, and diet rich in salt and red meat are causative factors. One thing that is important is your management of your blood pressure, so that everybody should have a sphygmomanometer, is what we call it, a blood pressure monitor at home, and they should take the pressure at home so that white coat hypertension doesn't enter into it. White coat hypertension is the high blood pressure that you may have when you go see the doctor and you get excited. Uh, so that medical checkup and also you monitoring your blood pressure at home is really the way to do it. And so if you don't have a blood pressure monitor, you need to get one. And then you need to do it yourself and see if you're close to the 120/80, which is desirable. And then, of course, as we've talked for many times, obesity and overweight play a larger role. And then, of course, stress, lack of meditation, etc., uh, is lethal. Any comments or questions about this? This is something that we kind of take for granted sometimes, but sometimes it's good to go to the elements of a disease that ravages our people of color.
I had a question, Doc. How accurate are those home uh, pressure monitors?
They're accurate. But one of the things you can do is, if you have any doubts, you take your sphygmomanometer or blood pressure monitor to the hospital with you and get it checked by the nurses and the doctors to make sure that it checks. But for the most part, they seem to be pretty good. There are exceptions to the rule. So if there's any question about it, then you take it with you. We go to your doctor and let them take a look at the sphygmomanometer and see to make sure it's registering properly.
All right.
Yeah, I got a question. It seems that anemia can contribute to hypertension.
Well, there's not much association of anemia with hypertension. Anemia means that your hemoglobin, hematocrit are low, and there isn't much of a contribution of anemia to hypertension. It is more often associated with hypotension rather than hypertension.
I have a question, Dr. Callender. Do the doctors ever focus on the heart muscle that pumps the blood?
Always focus on the heart muscle because that's one of the most important muscles in the body. And so, if your heart muscle isn't functioning, you don't live. So EKGs and other things and echocardiograms are things that we do to try to see, because one of the leading causes of death is cardiac hypertrophy, where your muscle is enlarged, and this contributes to death in a great many factors. So that the heart plays a role, not necessarily in hypertension, but cardiovascular disease is the leading cause of death in the United States. Hypertension is one of the causes of it, because if you have hypertension, you can get hypertrophy or enlargement of the heart, which then may lead to heart failure. So,
well, what do doctors do to help strengthen the heart muscle?
Well, really, not what you want to have is make sure that the circulation is good and the coronary arteries are open. It's probably the best thing you do. And then exercise, which allows you to develop collateral circulation in the heart, is the other thing that you do because the collateral circulation allows the blood to circulate even if some of the major arteries are obstructed.
Thank you.
So the things that we talk about with meditation, exercise, and avoiding red meat and eating vegetables and fruits and are things that are helpful. And of course, avoiding obesity.
Dr. Callender,
Yes.
I have sleep apnea, and when I use my machine faithfully, my blood pressure always comes down.
Right.
And
Mhm. Go ahead.
and I it 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 I can tell the difference. I didn't understand the relationship between the sleep apnea and the blood pressure.
Well, as a matter of fact, obstructive sleep apnea is one of the commoner causes of hypertension because the fact that you are not getting enough oxygen causes everything to go awry, including your heart rate and your blood pressure. So it is a common cause of hypertension, obstructive sleep apnea. And so not only does your blood pressure come down, your ability, the acid in your body comes down as well. Any other comments relative to the blood pressure and cardiovascular issue? As we talk about kidney disease, hypertension and diabetes are the two commonest causes of kidney disease. So now this is something that I thought we might need to go over again because we have 3 vaccines that are arriving, and I say they're arriving because while the RSV is already here, the FDA has not yet approved the COVID vaccine. That will probably occur sometime next month, which is starting tomorrow is next month. So within the next 2 weeks or so, the coronavirus booster shot will be approved by FDA. But the flu vaccine is already here, and the RSV virus is already FDA approved. So that the expectation is that we will have 3 viruses that 3 vaccines that you will be able to take annually beginning late September and early October. Now, one of the issues that is a cause for, let's go back there. We'll come back. Let's go back to.
I'm sorry.
Yeah. Yeah. One of the issues is the issue that while the coronavirus booster shot will be available in September, it will only be free for those who are uninsured. I'm sorry, for those who are insured. And those who are uninsured will not be taken care of by that until October because the Biden's effort to make the coronavirus vaccine free for those who are uninsured begins in October. Now, this may seem a big concern, and it is, but the flu season really starts in late October, early November. So if you can, if those who don't have insurance get it sometime in October, it probably won't make a difference unless you're someone who has not been up to date and been received a booster. And we'll talk a little bit about that later. Now, this updated COVID booster is designed for the new variants, and it targets not only the XBB but also the EG.5, which is the new subvariant that comes into play. Now, the point I was making about the booster is that those of us who've had 6 booster shots and have had boosters within the last 6 months can wait for the October coronavirus booster shot. But the booster shot should not be taken sooner than 90 days from the time of your last COVID booster. So for those of you who had a booster within 90 days, you should wait. Now, for those of you who did not get the updated booster within 6 months, you probably need to get the bivalent booster shot as soon as you can. And this updated booster is recommended for all age groups once a year. And then item 8 talks about the issue about the federal government providing for the uninsured mid-October. And so that's one of the things that is problematic, is that for the uninsured, they will have to wait or else pay for it. And then the item number 9 talks about the fact that those who had their last COVID shot more than 6 months ago need to get the booster shot now, especially since the hospitalizations are increasing and the infections are increasing. So now the other thing is that there are articles that suggest that you get all 3 shots separately, and you don't want them all combined into one, because somebody asked that last time. And there's some evidence, not great, but that if you combine them, that you lose some of the potency of the viruses. So that the idea is that all of them should be given separately, and you want to give them before November, because that's when the flu season actually starts in November. So you want to have it. It takes about 2 weeks after you have the shot to be fully vaccinated. So you want to get it in October probably. And
Good
then
morning, Doctor.
finally, ounce of prevention is worth a pound of cure. And these are deadly viruses for people who are very young and people who are very old. Yeah, Kevin, what did you want to say?
Yeah, good morning, Doctor. Is there a time frame when they talk about doing them separately?
Oh, you can do it the same sitting, same
Oh.
time. Just you don't. In other words, you don't want them combined. That's all. But yeah, you can get the same sitting. You can get all 3.
Oh, okay.
Oh, okay.
Any other questions about that? About that this article about, because there's a lack of clarity of understanding about whether or not the coronavirus booster is available now. It has not yet been approved by the FDA. So as soon as it's approved by the FDA, then it will become available. The other 2 vaccines are available now.
I had a question, Doc. So I'm still not clear about what you just said about the 3 shots. So the 3 shots being the RSV, the flu, and the COVID.
Yes.
So they say don't get those 3 at the same time.
No, I said get them done separately. Don't have the 3 vaccines in one needle. You need to get 3 separate needles.
Oh, I mean, could you get them done on the same day?
Yes.
Oh, okay, okay. I'd never heard of having the vaccines combined in one shot, though.
I know, but in case anybody was thinking about it, they have done some research on that and have identified, because some people say, I only want to get 1 shot,
Okay.
not 3 shots. And so they've done some research on it, and it seems to affect the potency of the vaccine. So they are suggesting that that's why I said separately. And you're right, it is a little confusing, but that's why I thought it'd be good to let you shoot at it and give me some questions. So I didn't know how to make it any clearer than that.
Okay, and the other thing, so I got my 6th shot in May. That was my 2nd covalent. Okay, and for some reason I heard that you couldn't get the next booster with the extra coverage on it until 6 months after that shot. So that's May, June, July, August, September, October. I couldn't get it. I couldn't get my next COVID booster until November. Is that true?
No, it's not actually true. Remember, I said up there that it should not be done before 90 days. Now, after 90 days, It's okay.
Oh, okay.
Yeah,
Thank you.
yeah, it's okay, but it's just that the waning of the booster shot, it begins around 90 days, but it's good for 6 months. So if you wanted to wait till October, November, you could, but if you wanted to get it before then, you could also.
Okay, thank you.
Any other questions about it? It's important because I thought I'd put it out now before, so give you time to think about it and also and ask any questions you want to have about it for those who have questions about it, because this is the first time that you got 3 vaccines that you'll be able to get. We never had a RSV vaccine before. Flu shot we've always had, but RSV is new, and the coronavirus has not yet been FDA approved for the new booster shot.
I have to apologize, Doc. I just pulled down a letter from Kaiser about RSV, and I didn't get a chance to send it to you.
That's okay. No, that's good. Let's discuss it. That's next. That's good.
Yes, here it is.
Yeah, yeah. RSV is a very good, nice to have. This is a virus that has been very prevalent and has caused, for example, I have one of my doctors who had a very tough time with the virus, which was not COVID, and it's probably RSV. And of course, prior to this year, there was no RSV vaccine. All of the viruses were ineffective. And so now, for the first time, we have a protection for a virus that is a common cause of sore throat and flu and flu-like syndromes, for which we really had no protection. And so now we have a vaccine that is good for people who are older and people who are very young, because that's who really get the RSV, that it kills people. People who are over 60 and people who are under 3. And so so it's very good to know about this RSV vaccine. And I think some of our members here have been part of that vaccine study group.
I was.
Yeah. Yeah. So anyway, we now know that it is effective, and it's something that I actually have a monoclonal antibody product that also protects very young children and babies.
What are the symptoms of the RSV?
Same thing as the flu. Exactly the same thing. You have the same. You have the inability to smell things. You have the fever, the chills. It's just like the flu.
Okay.
Exactly like the flu.
Well, doctor, when you go to the hospital, how do they distinguish those two?
They do studies, do antibody studies. You get just like you have a study for the COVID virus, you have a study for the RSV as well.
So, Dr. Callender, when you go for a flu shot, are we to say we want an RSV?
Yes. Yes.
Okay.
Yes. If they don't tell you, yes, you want good RSV. Now, RSV has just been FDA approved a couple of weeks ago, so you don't have to rush for it. But it is FDA approved, and it will be available at the pharmacies shortly.
I had a physical yesterday, and he said, while you're here, you want to get your flu shot? And I said, yes. And then I said, no, only because during our sessions, you indicated before to try to get it in September, early October, which is when I normally would get it. So he said, well, okay, you can come back and get it. But now I know that I should be asking for or checking to see if it is an RSV.
Oh, yes, yes. Yeah, I think, yeah, because what is important to appreciate is that this is the first time we have had a vaccine for RSV. So some people may not be familiar. And so you may have to ask for it. For the coronavirus, it's not FDA approved. The new booster is not FDA approved yet. But the flu shot is already here. So, but I still feel that the time to get it is October or November.
Right.
Yeah, I'm hearing a little bit of confusion, Janice. It's a flu vaccine and a RSV vaccine. It's not either or. It's two separate.
Okay. Now that's what I'm asking.
Yeah.
Yeah. Is
It's
it one, but it's two flus
No,
and
no, one flu, one RSV, and one coronavirus.
good grief.
3 separate vaccines.
okay.
3 separate vaccines, and you may have to ask for it. And if they don't have it, then you have to wait till they get it.
Okay.
The flu shot is available already, but I
Right.
don't recommend it until October.
Good. Okay. Thank you.
Any other questions? Because I think it's important to think about it and yeah, think about it. As I mentioned, I had a friend of mine who had a virus, one of my doctors, and it was COVID negative. And so they wondered what it was. It's probably RSV. And because it's not been available before, nobody thought to ask about that. But anyway, everybody want to know, well, is it COVID? So if it's not COVID, it could be another virus, and the other virus could be respiratory syncytial virus, RSV. So, and then what's going on with the COVID vaccines? We mentioned that it is likely to be FDA approved within 2 to 3 weeks from now, and yes, it is different, and this is a new vaccine, as we mentioned before. And the concern is that only 17% of the American population got the bivalent vaccine. And so that means that a lot of people, their protection is running out. And then there's the next question. I just tested for COVID-19. Should I get Paxlovid? That depends. If you have no symptoms at all, you probably don't need to. Paxlovid has its own side effects, so that if you're asymptomatic, there's no need for it. But if you are symptomatic, then and you're above 50, then it is recommended. And then, of course, the closing is what we all know. You got to wash your hands, and also, it's still wise to wear masks since we're having more hospitalizations. And then this last closing is get enough sleep, balanced diet, fruits and vegetables, and manage your stress, meditate, and everything else. Any other questions about any of this? Because this is the time to discuss it. Bill Early, you'll have more articles about this as the FDA approves the updated booster shot, and as the RSV vaccine becomes more available, and as the flu shot, which is already available. So it's 3 separate vaccines for the first time. Okay, and of course this is put in for repetition is that it will be available later on in September. It's not available yet because FDA has not approved it, but it will be available. And when it becomes available, then we recall that it won't be free for the uninsured. That's a troublesome point. where
Mhm.
you got a disparity between the insured and the uninsured. So, but that will be for a short period of time, 2 to 3 weeks, because by October, uh, that should be taken care of. But it is uh, a disparity because in the past, the vaccines were free. The COVID vaccines were free. That will not be the case this time until mid-October. Any other questions about that? Okay, so we're early on, and of course, this is an article that points out that already have had some schools here in Kentucky where COVID, flu, and strep outbreaks cause them to close school now, and but that hasn't happened anywhere else that I know of. But there is an increase in the number of COVID infections and hospitalizations. So that's a warning sign. So when you go into closed spaces, it makes sense to wear your mask.
Dr.
Okay.
Callender, it seems like there's a war going on, right? And the viruses are winning.
Well, they're not winning because what we want to do is the vaccines are to prevent hospitalization and deaths. So if as long as you don't require hospitalization and death, then I don't think they're winning. But that's a matter of opinion. But anyway, because our vaccines, that's the goal, to prevent hospitalizations and deaths. But the viruses are ever present.
Dr. Callender, do you think that there's ever some fraud involved with this? Because, these companies are pushing FDA to approve their products. So are they selling out and buying officials of the FDA, anything like that?
I don't know. That's the answer. I couldn't give you. I do know that Pfizer has been trying to get their product through. I don't know about the other companies, but I'm sure that they are trying to get their products through. I don't put anything past people trying to get through, try to bypass the rules and regulations. So I'm sure there's some people trying to do that. Whether they are able to successfully do that is a question I can't answer. But I think the spike suggests that wearing masks again might be safe if you're inside, for sure. Outside, I'm not so sure, but inside, sure. But I can tell you this, when I've been inside, I haven't seen anybody else but me wearing masks. So
That don't bother me. I wear mine.
Me neither.
yeah.
This article is about the DC, Maryland, and Virginia.
Yeah, that's where the
Right
uptake.
here.
Yeah, right. Okay. I think we're forewarned, and being forewarned is to be forearmed. Forearmed. So, okay, I just put this in case you wonder about the invincible doctors that suicide is far too common, along with peripheral arterial disease, and burnout. And I guess we've talked about this for a while, why do doctors burn out and why do they commit suicide? And there's a lot of conjecture about it. One of the issues is that some are afraid if they go and get help for their suicidal ideation, they may lose their jobs. And then there is medical errors and a large workload, and then depression and many other factors. But 6% of the participants had suicidal ideation. I don't know whether that's considered large or not. But anyway, 6% didn't seem very large to me. But anyway. And you know the new suicide number, but that's something that doctors are likely to use. The real need is for doctors to be able to go and get psychiatric help when they need it. And there's a lot of fear that if you get mental health treatment, that you could lose your job. And so we've got to do something about that aspect of it. Yes,
Dr. Callender,
yes.
do doctors still have to, when they're interns and residents, do they still have to work those long shifts like they used to in the
No,
past? Do they still do that?
no. Although that's problematic in the sense that they don't do that as interns and residents. But then when you get out to do practice, then you find it's different because you have to take care of patients when they're sick.
Right,
They don't only get sick between 9 and 5.
right,
So,
right.
so yes. So while they're interns and residents, no. But as soon as they get out into practice, it's different. So
Right. Okay.
that's a kind of a hypocrisy there. But anyway. But the answer to your question is no. They have a 80-hour work week that is strictly adhered to. Wellness is emphasized during the residency. It wasn't emphasized before, but because of these data like this, because we have residents as well who are committing suicide. So, so things have changed, and so they do not have to work those long hours. Although in many ways, it's not really that wonderful because once you go into practice, then you do have to work long hours. So, but anyway, the answer to your question is no, they do not have to work the long hours that they used to have to work. And wellness is emphasized in internship and residency, where it was not emphasized before. Because we were always taught that patients came first and that we were second. And so, but anyway, that has changed now, and wellness is one of the most important aspects of the training programs.
Dr. Callender, I think that we have talked about a doctor who is facing $1 million lawsuit because of I think he amputated the wrong leg of a person, and so he committed suicide. Anybody remember that?
Mm-hmm. I remember something like that.
We have many instances of medical errors and uh, doctors thinking they're infallible when they are not. So one of the important lessons to learn is that doctors are humans. They make mistakes.
Dr. Callender, is that why they mark the part of your body that they're gonna work on?
Yes,
That's a good
exactly,
idea.
exactly right. Mhm.
What's the average number of hours a week that a doctor works?
Are you talking about somebody's in training
Somebody that's
or
been in practice for a while.
oh, okay. Well, it depends. See, feels like surgery, neurosurgery, uh, 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 they may average about 80 to 100 hours a week. Uh, Feels like dermatology and radiology, they probably average about 40 to 60 hours a week. So it depends what specialty you're going to, but uh, uh, specialties like neurosurgery and cardiovascular surgery, uh, they may sometimes go up to 100 hours a week uh, because some people have very busy practices and some people don't. So uh, it kind of depends upon uh, your notoriety and whether people really want your services. Uh, in places like in areas like neurosurgery and cardiovascular surgery and areas like that. Internal medicine, for the most part, unless you're in if you're pulmonologist, uh, especially when in the fall season, uh, they probably get close to 100 hours as well when you have the flu seasons and those kind of things. Uh, but it's really specialty specific, and so that during the fall season, the pulmonologist may work up to 100 hours a week, but the surgical specialties tend to the ones that have to come in at night and do those kind of things. The emergency rooms and urgent care centers take ease some of that burden, though.
To me, that almost seems criminal to work up to 100 hours a week. I mean, what kind of life can you have working up to 100 hours a week? I'd be depressed and ready to commit suicide too.
I wasn't depressed, and I wasn't. I thought that was what we were created for.
Well, okay, you're better than I am.
No, I'm not.
I'm
It's
just
not that
I'm
I'm
just
better.
speaking. Yeah, I'm just
It's not better.
speaking.
It's just that I had a different mental attitude towards it. I thought that's what I
Yeah.
was created for.
Yeah.
All right.
I see it as commitment on Dr. Callender's part.
Oh,
Um,
absolutely.
I'm
Yeah.
only one of his hundreds, maybe thousands of patients. And throughout my husband's illnesses, Dr. Callender had always been there and without hesitancy. And I said, if he's given him that kind of attention and given that attention to all of his patients, I don't know how you do it either. You put in a lot of long hours. And it made me feel good those evenings when you were leaving the hospital, walking to catch public transportation, and you went to a basketball game or something. I said, go ahead, he is real. But you're a special person. You're a special person. So it
Well,
takes a
I really believe that when they said patients come first, I thought, of course, my wife doesn't like it either,
yeah.
but I was committed to it, and I guess that's what that I was always committed to it. So it was never any. I never felt an obligation to do anything differently, and I was never depressed or anything like that, because I wanted to be a doctor because I wanted to take care of people, and so I really believe that patients came first. So no point whether patients survived and thrived or not. I felt the obligation to give it my best shot always. But I think the point that you're making is a good one, Darryl, and that is that everybody isn't like me. And nowadays, people want to live normal lives, which means they want to have 40-hour weeks. And who's to argue with that? It's just that I was brought up in a different era with a different mindset. And the mindset was that the patients came first.
Yeah, when I think
Doc,
back, I had a general practitioner. She was a Russian lady, and she was in her late 70s, still practicing, and obviously not enjoying it. And I asked her, "When are you going to retire? Do you have any other interests?" And she says, "Well, I'm not going to retire because I don't have anything else to do. This is my whole life." And uh, when you are working long hours, I was talking to a urologist last week who's 65, and it's kind of rare that he's going to retire. That's kind of early for a doctor because most doctors retire late 60s, 70s, or 80s, or never retire. And but he's got a lot of hobbies, and so he says, "Well, I'm tired of working 50 hours a week. I'm going to retire and enjoy life." Um,
That's interesting. I
just
enjoyed life. See, that's the difference. It was fun to me taking care of patients, and of course, it was more fun when they did well, and it hurt when they didn't do well. But it was, and then even now, for example, although I'm not taking care of patients like I used to, I do other things that keep me involved. So that, and I always have had hobbies. I mean, I sing not like you, but I sing, and uh, I enjoy life, so that hobbies were always part of my life, even when I was busy. I still uh, enjoyed church, and I enjoyed basketball games, and I enjoyed playing basketball and singing and stuff. So that all of it was part of my life, and so I've enjoyed life. It's almost like I never worked a day in my life. All been fun. So that's what has helped me. Now, I think you're more realistic than I am, and that so people talk about to live. I consider myself to live. Uh, so I did my hobbies all the while, all the time anyway. So that's what made me different, I suppose, because from the time I was 7 years of age, I wanted to be a medical missionary. So it's something that I've always wanted to do all my life. So it's not something that just came up. It's something that I felt that I was created to do. And so I gave of myself totally. But while I was doing that, I still was enjoying life. I've had family life, and I've had so even now as I do all of the things that I do, it's still kind of still fun for me, and I still do all the things I used to do in terms of singing and enjoying life, so to speak. Anyway, that's my commentary.
And Dr. Callender, I also want to thank you for being my brother James's doctor, because you were not only a doctor for James, but you were always also a mentor for James. And that was, you came into his life when he really needed you. And I know my family, we really appreciated all that you did for James. And we
Dr.
thank you.
Dr. Callender,
Yes.
I always was of the impression that doctors, nurses, ministers, those people got callings.
Mm-hmm.
That was my understanding of how the healing the healing arts, the healing of the soul or the healing of the body, those people had callings to do their work.
It's
Well, I
true.
guess what I've told you is that that's exactly how I viewed it as
Right,
well.
Mhm.
right. And when you have a calling, then that's different than just an occupation.
True.
Nice way of putting
And
it.
you live your life in a balance.
Mhm.
And that's the important thing. If it's your life mission, then your total life.
That's a very interesting way of putting it, because one of the things I learned along the line was that the most important thing about everything else is balance. And
Mhm.
without, I learned that later on because uh, I was totally committed, but I encountered people who were successful, and they were successful because they were balanced.
Mhm.
And just like, for example, Darryl is interesting and balanced because after he's retired, he's become a great entertainer. And so his life now is basically that of as an entertainer. But and so the other life he lived was kind of like a different job. And so anyway, that's interesting perspective. Let's hear some other ideas about that.
Dr. Callender, a while back we were talking about child geniuses, and I thought about it some more, and I had come to the conclusion that there were some geniuses that were well balanced, and some geniuses weren't.
Yeah.
You got these geniuses like math genius. They were so good in math, but they couldn't have a conversation with anybody. They couldn't swim, couldn't play baseball. All they could do is just math. They were just so good. But then you have those geniuses that are well balanced, that they excel in a particular field, but then they can also play baseball with you, or they can go to a party with you, those kind of things. What do you think?
I think you're right on target. And I think when we had that discussion, that's the part that we didn't talk about. It's interesting how we talked about Darryl, who was a child genius, who also was balanced
Well
because
balanced.
because he set up this program for the kids,
Oh yeah,
although he charged them.
sure, right.
But it shows that he had a balance about him in spite of his genius. And I think you're right on target on the balanced aspect of it, because I've seen a number of these geniuses who had no balance at all, and they often died early.
Dr. Callender, you played basketball, didn't you?
Oh yeah. I played basketball. I wasn't that good. The only team I made was my Hunter College freshman team, but that didn't stop me from playing. I enjoyed it, and just like singing, I love to sing. Doesn't mean I'm a good singer. It means I love to sing, and it's fun, and it's therapeutic.
Your friend from school, John Buchanan, that plays the saxophone, the eye doctor. He
Oh
told
yeah,
me he likes to practice eye surgery, etc. But after he does the surgery, he goes and plays his horn.
that's that balance you talked about. Right.
Exactly.
Mhm.
He's always been like that too.
Yeah, I think you put it well. So, okay, let's go on to the next topic. But I'm glad you brought up those points, Darryl. Now, this is something that we know well, and it's not been easy to get this message across that the earliest sign of kidney disease is protein in the urine. That's called albuminuria. And one of the things that's bothered me is that when people over 50 go in to get their annual physicals, they often do not get proteinuria testing or albuminuria testing. And to me, this is very criminal. And particularly for people of color, where 40 to 50% of the population over 40 has some element of kidney disease. And so the time to get it diagnosed is the earliest possible so that you can do something about it and prevent the protein in your urine from destroying the kidney. And so this is something that is underappreciated. Look at this, 17% undergoing albuminuria testing. So to me, if you're a person of color, you ought to have that done every time you have your annual physical. And this is not done. And how do we get that message across? That's what bothers me, is that people don't understand that for us, people of color, we need to have this done every time we get our annual physical when you're over 50 and you're Latino or Native American.
Dr.
But
Callender,
yes,
is that something that's visible, or is it only detected through testing?
only detected through testing, because your BUN and creatinine would be normal, but you could still begin spilling protein in your urine. And that's the earliest time you can find out about kidney disease, and that is not done. And that's probably my pet peeve, is that we do not emphasize this test enough, particularly in people of color.
Does Medicare pay for the testing?
Yes,
Mhm.
but I think you have to. Here's what is the problem, and you hit the nail on the head. You have to identify why you're doing the test. You know, if you indicate that this is somebody who's over 50 and that this is something that is particularly important for that particular ethnic group, then they will pay for it. But
Mhm.
just do it without indicating the reason. That's why you have to have the right diagnosis. So if you have the right diagnosis, you could get paid for it.
As I said, I had a physical yesterday and I had to give urine, so I'm assuming that's one of the things he's testing.
But you need to ask about it,
Okay,
because the assumption may be incorrect.
right.
And here's the other thing. They may do the test and not even pay attention to the
Mhm.
protein that's in the urine. See, after you find out that you have protein in your urine, then you got to do something about it. So it's not good enough just to find out you have protein.
Right.
You got to follow it up, and that's
Mhm.
what is missing for most of the situation. And
Is-
that's why in our screenings, as Joyce knows well, we do blood pressure tests and we do protein testing in the urine. And then once we find if you have protein in the urine, we refer you to a nephrologist for follow-up. And so that follow-up is the critical aspect of it. So it's not good enough to know that you have protein in your urine. After you find out you have protein in your urine, you have to do something about it.
Is that the creatinine level?
No, creatinine level is later on, because most people who have protein in urine have normal creatinines. But it's only 10 years later that they may have, and 5 or 10 years later, they may have evidence. But if you have protein in your urine and you have an elevated creatinine, well, you really have to get that taken care of.
Okay.
Is there a
Dr.
time period to
Callender,
get
what
it
do you,
included?
Both of you
Go
spoke
ahead,
at the
Mariel.
same time, so
I'm sorry. I wanted to know what the name of the test you asked for. I'm looking at
albumin,
my,
Albumin.
albuminuria or protein in the urine.
okay, I have that. I have an order every 4 times a year where I get my urine and blood tested because I have diabetes. And that's one of the things on here. So what should it say? 0? That test should come up 0
Well,
with protein, or what?
there's
What should it
a
say?
normal, I think less than 30 milligrams.
Okay.
There's a
Okay.
greater than 30, greater than 100. But
Okay.
you should have none, but if you have greater than 30, then that's important. And especially if you're
Okay.
diabetic.
Okay. I'll be looking for it.
And then
Is there
you should ask your doctor about, am I spilling protein in my urine?
Okay.
Right. So it's important to, especially for us who are over 50 and people of color. It is something that is underutilized. This article says it well, underutilized, very much underutilized. Proteinuria, albuminuria, same thing.
Is there a time period to have additional testing included in your annual physical? Like, say, if you have a physical September 1st, do all additional tests have to be done within like 30, 60 days after that? Or
I think once a year is good enough. But if you are found to have proteinuria, then you might want to do it every 3 months or so. Because then they have to look at you and find out why you have proteinuria, to find out whether you have a genetic disease or you have other diseases. Take a picture of the kidney to see if it's normal size, see if you have cysts, see if you have any other abnormalities there. And then, of course, look at the BUN and creatinine. If they're normal, do not be deceived, but to recognize that in spite of it being normal, this is the time for you to look at the GFR, glomerular filtration rate. And it should be 100%, but if it's not 100%, for example, they say here should be greater than 60, but to me, that's actually not the case. Perfectly normal is 80 to 100, and if you're less than 80, to me, that's a concern. If you're spilling protein, now if you're not spilling protein, that's different.
Dr. Callender, are the blood vessels in the kidney smaller than other organs, like they are the size of capillaries?
Yeah, well, you have capillaries in every tissue, but we have special glomeruli in the kidney and you have nephrons in the kidney that are specially gifted to do special aspects of filtering out things. And one of the things we filter out is protein, and we filter out other things. So that the filtering process of the kidney is one of the most important jobs that it does. And the protein is retained normally, whereas with the kidney disease, protein is filtered out, and that's a sign that the kidney is damaged.
But I mean, are the blood vessels smaller than other organs?
Blood vessels are small in every organ, because all of the organs have capillary. They all have the small vessels. They have big and small vessels in just about all of them. But the kidney is unique in that it has special capillaries and other small vessels and other tubules that work and eliminate sodium, potassium, and protein. Okay, I think I've dwelled on that maybe too long, but it's something that I guess all of our screening efforts are about that. Now this is talked about herbal remedies for type 2 diabetes. Now, remember, type 1 diabetes is associated with no insulin at all. Whereas with type 2, you have insulin, but it's not functioning. And whether it's because you have developed antibodies or whatever, the point is that type 2, and these are some of the herbal remedies that have been found to be effective at treating diabetes, because it is thought that for some reason your insulin is no longer, you have antibodies to your insulin, is what many people think. And so these medications, they think, and one of the things that you see commonly is the apple cider and the turmeric, which is commonly found in Indian foods, and cinnamon. And these all seem to make the insulin resistance, which is what is the problem with type 2 diabetes, is that the body's resistant to the insulin that you have. And so these herbs try to reduce the insulin resistance that you have. And they make the insulin more sensitive, to make the body more sensitive to the insulin that you have. And so this then allows for hemoglobin A1C to become normalized. And so for people with type 2 diabetes, they're suggesting that these herbal remedies will decrease the insulin resistance that you have and make you more sensitive to the insulin that your body produces.
Dr. Callender, can I ask Darryl about these fenugreek seeds? Have you heard of them before? I never heard of them.
Fennel?
Fenugreek.
You said fennel root?
Fenugreek.
Oh, that. Oh, yeah, fenugreek. I have no idea what that is.
See, you finally get something that Darryl doesn't know about. Finally, after all these decades.
Well, you know, I've taken your lead and example on that. If you don't know something, you just say, I don't know.
Well, that's the best way. And but it's rare that you say I don't know. I say it all the time. It's rare that Darryl says it. He's a real encyclopedia. Our hero.
Need better heroes.
Any other comment about that insulin? Because remember last week, John Buchanan was really unclear about what is meant by insulin sensitivity and insulin resistance. And I think the term that we didn't use that might have clarified it a bit was insulin resistance, because what happens with type 2 diabetes is that your body becomes resistant to the insulin that you have. And so you need something to make the insulin more sensitive, the body more sensitive to the insulin. And insulin resistance is what causes type 2 diabetes.
Yeah, a couple of those herbs that were in the article, turmeric and ginger, I cook with those daily. They talked about apple cider vinegar. I probably don't use that as much as I should, but I did use it very effectively last Saturday at the cookout because I got attacked by mosquitoes. They really like me, and I put some apple cider vinegar on the bites and got instant relief.
Wow, interesting. Okay, thank you very much, Darryl. Good point. Well, this is something that is helpful to many, of course. One of the things that is interesting about many of the things we talk about is it reinforces many of the other things that we've talked about. And so these 10 recommendations include many of the things we talk about. Maintain a healthy weight. Of course, few of us can be as ideally weighted as Darryl is, because he's what are you, about 20? BMI is about 20?
21, I think. I'm 6'2" and 165.
Yeah, wow, that's ideal. I mean, I marvel that they can do so well. And then, of course, we can't be like Darryl, but we can be closer to that. Physically active every day, all of that, all of these things contribute to good health and also minimize the cancer risk. Don't eliminate, but minimize. And then emphasis on vegetable fruits and beans and whole grains. Then incessantly we talk about, I don't know whether we practice it, but we cut down on fast foods and processed foods. And then limiting intake of red and processed meats. Talk about forever. Limiting the intake of sugar sweetened drinks, alcohol consumption. And then if you do that, you don't need the supplements, but some of us still need supplements. And then they talk about the need for vitamin D for some, folic acid and vitamin 12 for some. After you get over 50, some of these things become important. Then they talk about the role for breastfeeding for mothers and babies, although how that protects against breast cancer, I'm not sure, but it is well known though. And then, of course, all of the above after a cancer diagnosis or before a cancer diagnosis. So I think that those are some important points to consider as you think about maintaining and retaining your health and the degree of health that you have. Any other comments about how to stay healthy, how to reduce your cancer risk?
Yeah, Dr. Callender, I have a question. All of these suggestions, good health, exercise, etc., they all seem to relate to keeping your immune system strong. And
yes,
so
that's correct.
Yeah, that's what helps.
That is correct. That is correct. It's interesting. As you say that, it makes you feel that cancer may be some kind of an infection. But one of the things that is remarkable is that when we have done studies to find out what causes cancer, we find out that our own immune systems are the enemy. And very often we have autoantibodies that that prevent our own antibodies from killing the cancer cells. And so it's almost like cancer is an infection. And if our antibody and immune systems were working right, they would eliminate the cancer. But what has happened is we have some autoantibodies that actually prevent our immune system from functioning the way they're supposed to. Any other comments or thoughts as we move on?
That's that war that John Buchanan was talking about.
There's the what?
The war between,
the war. Yeah, right.
Antibody.
Right. And that's why, as you pointed out, the immune system is the thing. And of course, for transplantation, it's just the opposite. In the sense that we try to keep your immune system from attacking the kidney. So but it's interesting the world we live in and the wars that are fought between the bacteria and the viruses and the protozoans in our bodies. Okay, next article. Well, I put this in just to point out that, there's so many aspects of health. One of the aspects is the genetic aspects. And as we do more studies, we find that there are many aspects. Genetics is just one of them. And we cannot eliminate genetics. And in this situation, they did many studies and they found out there are genetic mutations that are associated with heart failure. And they found 18 new ones. But wouldn't want you to believe that it's a genetic factor alone, because while these are genetic factors, it's the genetic factors plus your body system that together allow for heart failure and other disease entities to occur. So genes is part of the issue. The other part of the issue is how you take care of your body. And so so we have to keep in mind that yes, genes and genetics are part of it. The other aspect of genetics is the extent to which your personal information about your own genes can be abused or misused. And so whenever we do the genetic testing, it has to be important that it becomes our own information and not suitable for sharing with anybody other than you and your family physician. So that knowing your genetics becomes important, but keeping that important genetic information where it belongs becomes equally important. Any other comment about the genes? Because we know that they play a role, but we also know that the environment that these genes find themselves in plays as big a role as the genes themselves.
Is there any genetic testing that's available?
Yeah, well, you mean for heart failure?
No, just to have my genes tested to see which what hereditary problems that I might have, or
Yes, genetic testing is available, and your doctor can make that happen.
I'm aware of the 23andMe does genetic testing. They are usually associated with not necessarily heredity, but family trees and things like that. But they also do genetic testing over the families. So if you're searching for your links back to Africa, at the same time you can also get your DNA tested for your genes.
And keep in mind, the point I'm making that I don't want you to miss is that your genetic information is your genetic information, and that should be kept private. And you know, in your search to find out where you're from, and that's a different entity as that which is associated with disease, because the genetic association with disease has the possibility of it being misused, and if that gets out, it can affect your insurability. So
I had a question about that, Doc, because they offer those tests for genetics of all different kinds of issues, whether it's taste or propensity for skin cancer or any of those things, but they offer it. They don't automatically do it. So, I've always wondered, and I've said, no, I don't want to do the genetic testing part. I just want to, find out where my great grandfather was from, that sort of thing.
that's safer. Now here's where it becomes important. If you have a relative who has cancer, then you might have that person tested for genetic diseases. If that person's genetic diseases are familial or hereditary, then the whole family might want to be tested. But herein, that's where you have to be sure that that information is kept within the family and the physician, so that that becomes very personal. But I think your approach is a good one in terms of, however, when a family member does find out that they have a hereditable genetic disease, then the whole family may want to be tested, because there are certain genetic diseases that require prophylactic surgeries to prevent you from getting certain cancers.
Dr. Callender, I got your point, because you certainly can't let that stuff and your information get out to your insurance companies.
That can be dangerous, yeah.
Or your employer.
Or your employer. Yeah, yeah. Because that may make you higher risk for them, which may mean they don't want to insure you. Yeah. So, okay.
Well, it may be a good idea to get genetic testing on a prospective marriage partner.
Well, that's when it is also recommended. But here again, you just want to be sure that whatever information you get is private. That's all I'm saying.
Yeah,
Because yeah, you're right. Because you want to know if they have propensity for sickle cell disease, those other things. So that yeah, when you get married, it is that's another opportunity.
Right, and it may be passing genetic diseases on to children,
Absolutely.
which, if you're that age group where you're going to have children, that may affect your decision whether or not you want to marry that person.
Yeah.
Or you find out she's your cousin.
Those things, the one thing about genetics is that when you get the results, they may not show you exactly what you wanted to see.
Yeah.
They may show you
Be
something
careful
else.
what you ask for.
Yes, yeah, that's why you have to be careful when you get all those tests.
Yeah, I recommend that movie Gattaca, if you can find that. It's probably on YouTube. The whole movie's probably out there on YouTube. But check that out. As a person was switched his genetic sample with his brother, so he could, become a space traveler, an astronaut. And he switched his. He had to do everything to keep his cells from being collected, even hair or skin, from the government. This is way in the future, but if you get a chance to watch that movie, check it out. Gattaca. That's the genetic code, Gattaca.
Yeah, I think I'll get that. Yeah.
Very interesting.
Yeah.
What's interesting to me is that when you're elderly, you don't care about gene testing, when your grandson or your great grandson might want to know about you, but you don't want to know about yourself.
You think it's too late, huh?
Too late. 80 years old, genetic testing ain't going to help nobody.
Well,
May help
they
you
won't,
get
they
to
won't help you, but you're right. They may help your grandchildren.
If they find out, if you let the cat out the bag.
Okay. This is an article that talks about the many ways in which you can do fecal immunochemical tests and how that could mean fewer colonoscopies. And I think that colonoscopies have their risks. There are people who, although complications are very rare, they still occur. People still have colonoscopies, they have complications, require surgery, and some even die as a complication of colonoscopies. So these are tests that suggestive that they could avoid colonoscopies if they're negative, although the best test is still colonoscopy because they look at the colon from the cecum to the anus, and they find if there are polyps that could turn into cancer. thanks for putting that in the chat. So these are the tests that I think actually John Buchanan talked about having a positive test at one point and changing his diet and subsequently not having any more blood in the urine and the feces. So these are tests that they're talking about that may reduce the need for colonoscopy, although colonoscopy does work, right? So, but there are people who may not be able to undergo colonoscopy for one reason or another. And so these are people for whom these tests may make a difference. And certainly if you've got blood in the feces, that means that you need to have a colonoscopy. But if you don't have blood in the stool, it doesn't mean that you don't have a polyp. But anyway, it's because colonoscopy is not without risk, without complications. This is why these tests become valuable.
They have a test out, Dr. Callender, that's, and I know you know about it. It's called Cologuard.
Well, that's what this is. Yeah. Right.
Yeah. You bring that out and you do it at home.
Right. That's what these tests are all about.
Right. Send it to the lab. And
right. Yeah.
Get a report.
Yeah, that's what all of these tests are about. They're actually looking to see if you've got blood in your stool.
Right.
Yeah.
So also they look for genetic changes in the stool as well.
Yes, that's right.
Doctor, a friend of mine had gotten used the Cologuard and came out positive, I guess. But they recommend her seeing a doctor. You know, in the meantime, she's suicidal, you know, and I'm like, just have faith that it'll be all right. And she told me where to take my faith or put my faith. And, you know, she went to a doctor and everything was okay.
Was she afraid to go to the doctor first?
Pretty much, yeah. She didn't, you know, she'd already said, you know, she was 66 years old. She'd led a good life. And I was like, what? You know, yeah. So I was, you know, so, but yeah, she went and everything was okay.
Good. Good. Okay. All right. There's an interesting article about sleep apnea, which we've talked about many times, and that it accelerates aging, but the use of the treatment for the sleep apnea mitigates the acceleration of the apnea that occurs. And obstructive sleep apnea is, as we talked about, it causes many things to go wrong, including high blood pressure and hypoxia and low oxygen levels, and causes acidosis, many other things. But we weren't as aware that it also causes premature aging. And so they did this study. Of course, they haven't done as many as maybe we would like to. And of course, this is Brazil. But they did find that those patients who had their obstructive apnea treated, their telomere length was different from those who did not have their obstructive apnea treated. And as we know, telomere length is associated with longevity, shortening of life. So, of course, that means that you have to believe that telomere shortening is or what is associated with shortening of life. But since that seems to be the situation, the conclusion was that CPAP decreased the shortening of the telomeres. So this then led to believe that treatment for obstructive sleep apnea will lengthen your life. That's the conclusion with the So people age faster when they sleep badly. And when you have obstructive sleep apnea, you can't sleep well because you're fighting for breath all the time.
Yeah, Dr. Callender, I noticed that they were talking about moderate to mild sleep apnea.
Yeah.
And so it means that you could probably catch it early.
Okay, we've talked about this a number of times, that the sleep test that you have. The only thing we haven't talked about is the commercial about Inspire, and so maybe next time we'll do that.
Yeah, my apnea is mild, but it was recommended that I get it anyway because I was told, when I told somebody else that they were snoring, they said, "Well, you snore." I had my sleep test, and they said I had obstructive sleep apnea, but it's mild. My son has what's it called, severe. And it's the number of times you stop breathing in an hour, and I mean, just think about that. You're trying to sleep and refresh your brain, and you stop breathing. That's not good.
I think that severe, I think it was up at the top of the article. It was mild, and I think it was but anyway, I think I saw it.
Yes, yeah.
Mild and moderate.
No, moderate
Severe.
or severe.
And severe.
Moderate to severe. Right.
So yours is mild. That's good.
Okay, I think that should just I just put this in. This is something that they have mandated for all doctors, that they take 8 hours of training for administration of controlled substances. And there's the presumption, which I'm not sure that is accurate, that most of the fentanyl and all those other drugs are taken as a consequence of being put on medications inappropriately. And I think that is not actually the case. But anyway, that's what they believe. And so all doctors are going to have to undergo 8 hours of special training. And it's just one of the things that you talked about, how do doctors keep up? Every 2 years, they have to meet CME requirements. And these are the things that are required to stay up to date with what's going on. If you don't have these CMEs, you can't get your license. So if you wondered, how do we keep up to date? Well, these are required every 2 years in order to, if you don't get CMEs, you don't get your license. So just to let you know that there are a number of things that we have to do every 2 years. Otherwise, you will not be licensed to practice medicine.
Yeah, I know several people that were put on pain medication that it triggered drug addiction. So they they were in so much pain, they had to take the treatment, but it got out of hand.
Yeah, well, of course, the opposite situation is that many people who have chronic pain can't get pain medicine now because the doctors are afraid to prescribe pain medicine. But anyway, it's true that there are some. So anyway, this is something that is actually how we stay abreast. Okay, I think that should be the last slide. And did I see somebody have a comment or question? You're on mute if you're talking.
Thank you. Doctor, I wanted to ask, did you have any opinion on what might be wrong beside being an evil man Mitch McConnell might have with those episodes that he's having?
Who?
Mitch McConnell, the congressman.
I don't know anything about what he's having.
He has had 2 episodes where he's been like frozen. He's been talking on the in Congress or talking, and all of a sudden he can't move or talk or speak.
Oh, that looks like a TIA.
It's happened a couple times.
Yeah, so he needs to really be evaluated neurologically to see why, because that suggests that he has a transient ischemic attack.
It's almost like a stroke, right? Yeah.
Like a what?
Stroke.
Oh, yeah, like a stroke.
I watched Sanjay Gupta. He watched the video of the 2 times that Mitch McConnell froze, and he said, in his opinion, he wasn't having a stroke and it wasn't a seizure, but he's got a long list of other possible neurological problems that he may be having.
Well, he needs to be studied, right? They need to do studies. They can look at his do angiograms and find out whether or not and do EEGs. But there are ways they can find out what it would sound to me like a transient ischemic attack, which is preliminary for a stroke. But
Sanjay Gupta was saying that from what he observed, it was likely Parkinson's.
Oh, it could even be TIA, or it could be pre-epileptic. You know,
did anybody hear that it happened one time to Biden? I think I heard it happened one time.
But it could be petit mal, which is a form of epilepsy. Yeah. Okay, well.